that there are some side effects, unfortunately, that are very common in a number of these drugs. They share a lot of similar side effects, right? And so for me, what I want you to be able to know is just the drugs that cause diarrhea, typically, the drugs that cause nausea and vomiting, the drugs that tend to cause neutropenia. I don't want you to have to figure out in between, like, I'm not going to give you carboplatin, cisplatin, and have you tell me which one is more whatever. I just want you to be able to group these drugs into categories. And for some of them, there may be some specific drug interactions that are really important for you to know. Okay, so diarrhea is a significant side effect for which of the following medications? Select all that apply. So who wants to help me out?
Irinotecan.
Yes. What is the other term for irinotecan?
I ran to the can.
Yeah, I ran to the can. Okay, so we've got irinotecan. What else?
Ziv.
Yep.
Elfilbercept.
Yep, Ziv, elfilbercept. And what else? That's right. I love saying 5-FU. It's so great. Okay, what else?
Regorafenib.
Regorafenib. That's right. Incidentally, why do you think regorafenib causes diarrhea?
It's a multi-kinase inhibitor, so it's going to hit all the receptors.
Exactly. And because it's multi-kinase, so it's got a lot of on-target activity, right? Which means that it can have a lot of off-target activity as well. So when you get a drug that's a little bit less specific and can hit a lot of different kinds of targets like EGFR, VEGF, et cetera, you run the risk of causing a lot of different toxicities, and diarrhea is really a main one. Okay, what else? Or is there anything else?
Capecitabine.
That's right. What is capecitabine?
5-FU prodrug?
Exactly. It's just the oral version of 5-FU. Perfect. So for bevacizumab, bevacizumab doesn't really, like, in terms of all the different side effects it can cause, yeah, it's possible that it might cause some diarrhea, but for the most part, it's not one of the drugs that we really associate with diarrhea in these patients. And that's important because for colon cancer patients, many of them are getting a lot of drugs, right? So if you notice, for the most part, we're not necessarily just giving them one drug at a time. We're giving multiple kinds of drugs. So if a patient comes in and is saying, yeah, I'm really struggling with diarrhea, it's important to pinpoint which drug or drugs we think are causing that problem so that we can maybe consider changing up therapy or doing something else for the patient. All right. No. Next one. All right. I may have to hang on 1 second. Sorry. You'd think that they'd make this easier for the professor to actually show the quiz, but alas, that is not the case. All right, let me see if I can. Here we go. Okay, now it's working. Thank you guys for being patient. I appreciate it. Okay, so your 70-year-old patient will be receiving Fulfiri today. What is Fulfiri?
FU, irinotecan, and leucovorin.
That's right, exactly. Okay, so we've solved half the battle, right? So we know that this has 5-FU, leucovorin, because, and we'll talk more about leucovorin in a minute, and irinotecan. So he does not have any additional risk factors for chemo-induced nausea and vomiting. Which of the following pre-medications should he receive? So we're going to kind of take into consideration a couple of side effects that can happen with this regimen, right? So which one do you guys think is the best option for this patient?
C.
C.
Exactly. Can you walk me through a little bit why you came up with that?
Well, the patient doesn't have any risk factors for nausea, vomiting, so he can still have. So this would be like moderate emetogenic, versus if he did have something like motion sickness or like a prior history, then we would consider highly emetogenic. And then with the one of the drugs with Fulfari, I think it was was it the oxaliplatin? No.
It's
irinotecan. You have to add IV push atropine.
That's right. And the atropine, so some institutions now are doing like just small bags, like 25 ml bags, and running it over 5 minutes or so with atropine, and some institutions just give it push because it's a small enough dose. It's probably not going to cause any kind of tachycardia or bradycardia or arrhythmias. So one of the reasons the entire reason we use atropine is because the irinotecan drug molecule actually has a lot of cholinergic effects, right? So the body kind of mistakes it for a cholinergic drug. And so that what ends up happening is you get a lot of peristalsis. So your involuntary muscles in your gut start moving around, and people will say like they feel like there's a snake in their gut. And that is typically what causes the diarrhea and cramping. And then one of the other things that can happen is that people will have they'll tear up, they'll sniffle. And so we give the atropine to try and block that. And of course it gives them dry mouth, and they have, not usually constipation. The atropine normally has a pretty short kind of half-life in terms of getting them through the infusion. And it's not uncommon for us to have to repeat a dose of atropine when they sit in the chair. So that's something that's really important to remember about irinotecan. Bad diarrhea, it's a moderate emetogen in some, just like Karen said, in some populations of patients, it's a higher emetogenic agent. It can cause a fair amount of bone marrow suppression, but, typically we don't necessarily prophylax with Fulfari. And I would say compared to Fulfox with the oxaliplatin, oxaliplatin really is a bit more bone marrow suppressing than irinotecan. And incidentally, what is irinotecan's mechanism of action? Does anybody remember?
Topo-1 inhibitor.
That's right. Exactly. Nice. You guys are kicking ass, man. I'm impressed. All right. Next page, if it'll let me. Yes. All right. Select the correct statement about colorectal cancer. Diets high in red meat and processed foods are protective. Is that true?
False.
That is absolutely categorically false. We know that those are two things that probably correlate most highly with colorectal cancers. One of the reasons why the ratio of people in like the United States, for example, and the UK, and some other Western cultures who have such high rates of colorectal cancer compared to many other parts of the world, it's because of our diet. And then smoking and a lack of physical activity are not associated with increased risk. That's also categorically false. We know that smoking, a lack of physical activity, like significant alcohol consumption, diets high in red meat, high fat. Remember I talked about diets that are high in like very fatty cheeses too, that there was some concern. We talked about that with prostate cancer and like calcium signaling. There may be some of that also with colorectal cancers. One of the other interesting things is that right now there's evidence that vitamin D may be somewhat protective for developing or against developing colorectal cancer, as well as NSAID use. So there was a couple of studies that were done looking at like low dose aspirin, for example, and even some other NSAIDs because of that blockade of COX-1 and COX-2. And we know that that's part of that proliferation pathway in the epithelial cells in the gut. So then ulcerative colitis and increasing age are risk factors. Is that true or false?
True.
It is true. What did I say, though, in the lecture about age and how things are kind of changing a little bit? Do you guys remember?
Isn't it like it's coming to be like more millennials are getting it now?
Yeah, and we really have no idea why. It's not like, I mean, the diets of baby boomers versus millennials are, you know, probably many more millennials are eating healthier than baby boomers. So we really don't quite understand what's going on. So what's really concerning about this is, you know, again, I've noticed over the last like 10, 11 years or so that I've been practicing, I first started off having much older patients, you know, like 70s and even 80s. And now it's shifting into like 21, 22, 29. And many of these patients are being diagnosed later stage, which is really concerning. All right. And then 70% of cases are hereditary and caused by Lynch syndrome. Is that true or false?
False.
Yep. Exactly. So 25% are caused by some form of hereditary issue, right? So like Lynch syndrome, and there's FAP, there's all kinds of other things that we know increases your risk of developing colorectal cancer. And 70% of cases are sporadic, which means that it's probably related directly to these things like smoking, red meat, lack of physical activity, high stress environments, things like that. And then that 5%, you know, I was telling you guys that the math doesn't really add up. We're not entirely sure, but again, it could just be direct known exposure for people who are working specifically around chemicals or exposed to Agent Orange, et cetera. Any questions about that before I move on?
Yes.
Yes.
I have a question. Okay, so if the patient, they attribute the colorectal cancer to their diet, do you guys suggest that they change their diet when they're getting treatment?
We do, especially because if a person is earlier stage, which is hopefully when we're catching it, we know that their risk of having a recurrence is high, right? And they've already had that, essentially that double hit. So we do encourage patients, you know, I ask questions, I find out kind of based on their culture, based on their resources, what their diet looks like, because a lot of this is driven by resources or lack thereof. And unfortunately, that's why we see a disproportionate number of people who are poor and also people of certain ethnicities are more affected and have poor mortality rates as well because of that. So we do encourage people to try and eat as healthy as possible, get more fiber in their diet, et cetera. But, you know, for some people, they're kind of like, well, I got it once, you know, whatever. I'm just going to keep doing what I'm doing. It's, believe it or not, it's really hard to convince people to stop eating red meat or at least cut down on it. So yeah, great question. Any other questions? Okay. Great, did that one. So, they're out of order. That's okay. So DT has a left-sided colon cancer with metastasis to her liver and is KRAS, NRAS wild type with a BRAF point mutation, and no evidence of DNA deficient mismatch repair or MSI genomic defects. She's progressed again on therapy and wants to know what other options she has. So at this point, she's had Folfox, Camtasar, BRAF inhibitors, and EGFR inhibitor. So based on this, she's kind of toward the end of the line for therapies, right? Which drug would you recommend at this point?
Stivarga.
Yep, exactly, Stivarga. So what's the other term, or what's the other name for Stivarga?
Regorafenib.
Exactly. Now, because this drug is a multi-kinase inhibitor, it has, we talked about the diarrhea, but it has a whole host of other really awful side effects. One of the worst side effects that really is the one that makes patients not want to take the drug or we have to stop it is the hand-foot syndrome. and the rash. So patients have a lot of discomfort, a lot of pain, and many of them will get through like maybe 1 or 2 cycles and say, that's it, I'm not doing anymore. And now they're leaf blowing in the background. So great. Happy Tuesday. Okay. So before I move on, because I know that the concept of like left-sided KRAS, NRAS, BRAF mutations, right-sided cancers can be a little bit confusing. Does everybody feel fairly comfortable with what all of that means and why we kind of treat them differently? And if you don't feel comfortable, it's okay. All right. For just to make sure that we're all on the same page. So the NRAS, KRAS wild type, we exclusively see basically on left-sided colon cancers, okay? And that just means that they don't have a mutation that makes that pathway constitutively active. So I was explaining to a couple of your colleagues earlier that if you think of that family of kinases as kind of like a faucet, right? And when you have a wild type, when the EGFR inhibitor comes and it sits down on top of that faucet, it's able to turn off the faucet, right? Because it's not constitutively active. When you have a mutation somewhere in that spot, either KRAS or NRAS, that faucet continues to drip, right? Even when you have the EGFR inhibitor try and sit down and shut off that faucet. So in the case of people who have a left-sided tumor who are NRAS, KRAS wild type, but they have that BRAF point mutation, that BRAF point mutation provides another avenue for that to continue to drip. And that's why we have to add either Zelboraf, which now, as of like about a couple of weeks ago, we're probably going to be replacing it with another drug. But that's why we want to give a drug that's directed against that BRAF point mutation so that it allows that EGFR receptor, when it sits down on top of that, signaling cascade, it stops it completely. So that we're able to do that on the left side. On the right side, we're not able to do that. We're not able to overcome the mutations. And for whatever reason, and we don't understand it, we see that, the NRAS and KRAS mutations seem to really occur so prevalently in right-sided cancers of the colon that we don't even bother giving the Erbitux or Vectibix or anything like that. Does that make sense? People comfortable with that? Okay, because I know that it sounds super confusing. And again, we're not entirely sure what is going on with the cellular environments between the left and the right side of your colon that cause these differences. So hopefully we'll figure that out soon. All right. So back to DT. Okay, so before we got to Stivarga, her oncologist decided to start her on Zelboraf plus Camtasar plus Vectibix. So what would you counsel her regarding her Zelboraf? And this is actually a very common drug that we give for melanoma. So even if we're going to be using it less in colon cancer, you will see this drug quite frequently because there are a lot of BRAF mutations in melanoma. So which one do you guys want to counsel her on?
Atrial fibrillation?
That's right. Exactly. It's bizarre, but some of these kinase or these targeted therapies have really strange off-target effects. And in the case of Zelboraf, it causes quite a bit of photosensitivity, the arrhythmias we really, really worry about, and also, of course, the risk of QT prolongation. Also, it's a CYP3A4 substrate, so we don't want to give it with grapefruit juice, right? That's a no-no. And we don't worry about giving it with food. It doesn't really matter. Awesome. Any questions on this? And you know why we don't give it with Mechanist, right? That's not that drug, it's the other one. Okay. All right, so hand-foot syndrome is generally seen in patients receiving fluorouracil-containing regimens or with multikinase inhibitors like regorafenib. Is that true or false?
True.
That is true, exactly. Also, so Erbitux and Vectibix will cause a full body rash, you know, the acneiform rash that we talked about when we first started class. But we don't really classify this as hand-foot syndrome. Hand-foot syndrome is really, really different. It is truly just a severe inflammation of the palms of your hands and the soles of your feet. And in extreme cases, the skin can actually slough off, and it basically looks like third-degree burns. It's quite painful. One of the scary things about it is that it can progress very quickly. So as soon as a patient starts complaining of like, you know, I feel like my hands and feet are tingling, they're a little bit, you know, sensitive, we want to really start watching that. And we tell patients to make sure they don't wear really tightly fitting shoes, you know, same kind of advice that we usually give to patients who have like issues with diabetic foot neuropathies and things like that. One of the things that's hard though is that some of the regimens that we've talked about, one in particular can also cause neuropathies. Do you guys remember which drug that might be that we've talked about for colon cancer? It's the only platinum we've talked about for colon cancer. I'll give you that clue.
Oxaliplatin?
Exactly. So oxaliplatin causes a lot of neurotoxicity, right? And so one of the things that's hard is when you combine oxaliplatin with 5-FU, you're going to get the tingling and numbness and, you know, difficulty with sensation or strange sensation in your hands and feet potentially anyway from the oxaliplatin. And then in addition to that, you can get hand-foot syndrome. So the reason I'm kind of harping on this is it's really important to educate and counsel patients on, you know, what kinds of decreased sensation or, you know, cold sensitivity, things like that is important to differentiate between that and possibly hand-foot syndrome. So if their hand starts turning red or their feet start turning red, then we know that potentially that is hand-foot syndrome coming on. So that's really important. Okay. The next page. Oh my God. Sorry, today is just not going my way. All right, I'm gonna stop sharing here. Sorry. Now I've got a dog barking outside too. Like, I'm gonna start rocking in my chair. So if you guys see me, it means I'm losing my mind and I apologize. All right. Okay. I got it to work again. Okay. All right. Select drugs that commonly cause a hypersensitivity type reaction around the 6th dose. Select all that apply. So we've seen these before. So which ones do you guys want to pick? Do we want Herceptin? Nope. How about Platinol?
Yes.
Yes.
Perfect. And Paraplatin?
Yeah.
Yes.
Yes.
Yep. And what about Aloxetin?
Yes.
Yes. So some of these concepts, I'm hoping that you'll be able to remember because a lot of these drugs behave very similarly, right? We know that the platinums as a class tend to cause allergic reactions or hypersensitivity reactions that are IgE mediated between the 6th and the 8th dose. So that's one of the reasons why we may limit the exposure for a patient to maybe only 4 or 5 doses of oxaliplatin if we can. It's not uncommon for providers to drop the ox and just continue on with the 5-FU and the leucovorin. Any questions about that? Okay. You guys are like, no, just get through it before it kicks you out again. All All right, okay. AG is a 56-year-old white male with newly diagnosed stage 3A colon cancer. His oncologist has recommended that he have 6 months of FOLFOX. It's a lot of chemo. What types of toxicities is he likely to experience? So we kind of talked about this. Which of the ones do you think he's most likely to experience?
Nausea.
What was that?
Nausea.
Yep. So nausea is possibly one because it's a moderate emetogen, right? What else?
Cold sensitivity.
Cold sensitivity and diarrhea.
Exactly. So the cold sensitivity is from the oxaliplatin, right? And remember, I was telling you guys that patients, like even if they breathe air that's not warm enough, or they grab like even a room temperature cup of water or something like that, they can have a laryngospasm. And it was terrifying the many times I've seen this happen to patients because they're like gasping for air because basically, their cilia have just kind of frozen in place because of the oxaliplatin. Patients will usually experience the cold sensitivity even after they're done with therapy. So we normally tell patients to avoid all kinds of things that could activate this until maybe they're about a month out from having completed their oxaliplatin therapy. It's not permanent. And fortunately, that particular kind of neurotoxicity, I've never seen it be permanent, but it's very uncomfortable, and patients will become afraid of eating ice cream or doing, opening up the freezer door, fridge, anything like that. And then when it comes to neutropenia, we do see a fair amount of neutropenia, febrile neutropenia with oxaliplatin. So it often is considered an intermediate risk because it can cause febrile neutropenia between 10 and 20%. So sometimes we will give patients growth factors. The problem is we can't really give them Neulasta because the 5-FU, right, continues for a few days. And so you don't have a full 14 days in between chemo. So we'll usually give like Granix or Neupogen, something like that. Stomatitis or kind of the mucositis is also a really common problem with 5-FU. We don't really see it quite as much as the hand-foot syndrome, but it can be really distressing for patients. Any questions about that? Incidentally, the ataxia, when might we see ataxia in a patient who's receiving FOLFOX? And this would be a very bad thing.
If they happen to get acute cerebellar syndrome.
Right. And they would get acute cerebellar syndrome if they had a massive overdose. So remember I talked to you guys about, we give it as a continuous infusion, and it's supposed to be, it's a big dose that's given over about 46 to 48 hours. And there have been a number of times where there's been a mistake and maybe a nurse or pharmacist hasn't programmed the pump properly, and the patient will receive a dose over like maybe 2 hours or 3 hours. That can kill patients. And in fact, it's happened enough that we have an antidote, right, called Vistagard that we give to prevent this kind of death. So for patients who are experiencing ataxia and like the cerebellar syndrome, I'm going to be instantly worried that someone may have gotten an overdose because it's really not a typical thing that we see at kind of normal doses. Awesome. Good job. All right. I think we only have one or two more, maybe not. Yes. The following drug has synergistic activity with 5-FU and potentiates its cytotoxic effects.
Leucovorin.
That's right. Exactly. And there's another product out on the market called levoleucovorin. It's more expensive, so most of us don't really use it, but they created it because there was a massive worldwide shortage of leucovorin for a number of years. It was so bad that we were actually having the dose, and the guidelines even recommended giving half the dose of leucovorin because we couldn't get it. All right. And I think that is... yes. Your patient was diagnosed with stage 2 colon cancer. One of the medical residents you were working with would like to screen the patient's tumor for the following mutations: KRAS, NRAS, BRAF, DMMR, and MSI high. So would you agree to that? Would you agree to all of that testing based on his stage? I see shaking heads. I see people going no. Okay, so if that's the case, and that's correct, which ones would we want to test?
DMMR and MSI?
Exactly. So the BRAF, KRAS, NRAS class of mutations, or to see if they're wild type or mutated, we only worry about that for patients who are stage 4. Okay, because we're not going to use Erbitux or Vectibix or any of these other EGFR-directed therapies, or even potentially bevacizumab and some of the other drugs in the non-metastatic setting. So for the non-metastatic setting, we do still want to do the DMMR and MSI status, because it can help us determine whether or not chemo may be very effective in those patients. So if there's an opportunity to not expose someone to chemotherapy, then we'll take that opportunity. So good job. Exactly. And anybody have questions about that? Okay. And I think that is it. Wonderful. All right. So for your activity, so I was telling some of your colleagues earlier, and hopefully most of you heard this. So I'm having significant internet problems, and I'm going to have repair people come today. So I'm going to have to cut our time with each other short so that I'm able to actually hopefully use the internet for the rest of our class, and not have to use my phone as a hotspot, because it's also we don't have great reception here. So what I'm going to do is, this activity is actually going to take us through lung cancer, because some of the same drugs are used in lung cancer. And I think you guys are getting to the point where you're getting more comfortable with doing literature searches and looking through, articles, finding primary literature. But I want you to be really, really, really comfortable, right? As much as you can be before you go onto your appies, which eventually you will, I promise. It will happen. So this is a good way to get you guys ready for it. So I've posted on the Brightspace the questions that I want you to kind of answer, and also, of course, I want you to do the EBM questions as well. And really the idea behind this is, your group is a P&T committee, okay? And you are being asked to look at 2 drugs in the same class and decide which one you think is better for metastatic colorectal cancer, and which one you think should be the preferred agent. This is a common scenario that a lot of hospitals are dealing with now, because, since 2015, we've got more than 80 new drugs for oncology that are being approved. And the problem with that is that many of them are in the same class. So the question becomes, is it a me too, or is it really better than the older drugs that came out? Also, now with biosimilars, that's going to complicate things even more. So I want you to decide in your group, and there's not necessarily a right or wrong answer, but I want you to be able to justify your decision. Okay. So I gave you the first paper to kind of get you started for Erbitux and cetuximab, so you can kind of look through and see what some of the differences are, and then go from there to make your decision. And then for the bevacizumab versus ramucirumab, I want you to kind of start from scratch and try and find reviews, and then go through the whole process of, you may have to compare different studies for each of the drugs, like the landmark trials, and take a look at them and try and see, hey, does this one have a better overall survival compared to standard of care? Because a lot of what I have to do, there are often not head-to-head trials, because drug companies don't want to do that, because they risk having their drug is all of a sudden inferior, right? to another competitor, then that may make them lose share of the market. So a lot of times for me, one of the most important functions I have as an oncology pharmacist is being able to figure out, based on 2 landmark trials, which drug might be better for our population of patients. So I want you guys to do that. And then one of the things that we're going to do the next few days is really focus also on chemo person, so that you can really remember all of those side effects, because there are a lot of drugs now. Okay, so we will reconvene tomorrow, and then my P4s, I know you're on the line, so hang on and I'll chat with you after. We'll start this discussion again tomorrow, and we'll work through the activity tomorrow. And I'm also going to have to shift my office hours to tomorrow because of this as well today. So for those of you who I have exam reviews scheduled, we're going to do it tomorrow. If you can't, just email me and we'll make another time for you. And I apologize for the inconvenience. Cool. All right. Does anybody have any questions before I let you go and work in your teams and before we reconvene tomorrow?
I have a quick question.
Sure. What's up?
For the block exam too, how many packets we're covering? What?
Yeah.
From what to what topic?
Sure. So we're going to do 5 topics. Okay. So it'll be IRAE, breast cancer 1, breast cancer 2, ovarian cancer, and prostate cancer. That's it. Mm-hmm. I can add more if you want, but I'm kidding.
It's up to everyone. I don't care.
Yeah, no. I think so. I think actually, because you have less time to study for this one, 5 topics is fair, and I think for the next exam, just the 6 topics is better, right? Because you'll have a little bit more space and time to study for it.
Okay. Thank you.
Yeah. And the same number of questions. I may add in a couple of bonus questions to help get you guys over 100%. Woohoo! So don't freak out. If you see like a couple of extra questions, you're like, damn it, she lied to us. She was going to give us like an extra half an hour and only 30 questions. So if there are a couple of questions, I promise you they're just extra and just to, yeah. So, all right, cool. Well, then I will see you guys tomorrow. If you do have any questions about the activity, I'm going to be still answering emails. Okay. And you can also, you have my cell phone. If you need to call me, you can call me. So don't feel like I'm shutting down the Zoom and then, I'm going off into the abyss. I'm still reachable. It's just that I'm afraid my internet's going to be unstable, and I don't want to have to put you guys through that. And today's topic is not on the block exam. Exactly. Okay, cool. All right. If you guys need me, call me, text me, or email me. And otherwise, I will see you tomorrow, and have fun with this assignment, because really, truly, I promise you, this is the kind of stuff you're going to do on rotation and as a pharmacist. Cool. All right. Yeah. Is there another?
Today's topic is not in the block exam?
No, today's topic is not on the block exam. So not this block exam.
Dr. Leva?
Yes?
For the papers that we find, should it be specific for colorectal cancer, or can it be others?
Yes, it needs to be specific for colorectal cancer, because that's how we're going to make our decision. When we talk tomorrow about lung cancer, we'll do a search together for lung cancer.
Okay, thank you.
Yeah, no problem. Any other questions? Okay. All right, my P4s, if you can hang on and I'll chat with you quickly. And I will put the list on Brightspace to remind you all which topics. There seems to be some anxiety about that.
Thank you.
Okay, no problem.